Hello, and thank you for joining the POCUS Certification Academy for today's POCUS Bites webinar. My name is Tiffany Claiborne, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's topic is POCUS in cardiac arrest, the why, when, how, and who. And our speaker is Dr. Joshua Gutman. Dr. Joshua Gutman is an associate professor of emergency medicine at Emory University and is the former POCUS Fellowship Director. He has given over 90 national and international lectures and workshops on POCUS. He is currently the chair of the American Academy of Emergency Medicine, Ultrasound Section, and the reimbursement chair for the American College of Emergency Physicians. He is also the founder of Peachtree POCUS Consulting, where he helps build profitable POCUS programs and provides POCUS education. Let's welcome Dr. Gutman.
All right, thanks everyone for being here and coming. The over 60 of you, 68 of you, 66, something like that, that have joined at this moment. I'm going to make sure to share. Let's resume this sharing. There's inevitably technical difficulties that go on with these kind of webinars. So we're going to try to work through them if they happen. There we go. So hopefully you can all see this now. So again, hi everyone. I'm Dr. Josh Gutman again. I'm an associate professor of emergency medicine at Emory University and founder of Peachtree POCUS. Thanks so much for joining today's session, and thank you, Tiffany, for that introduction. We're going to dive into how point-of-care ultrasound fits into cardiac arrest management. And I framed this talk around 4 questions: the why, when, how, and who. Now, just to set expectations, I'm not going to cover the entire management of cardiac arrest. That's a huge, nuanced, and complex topic on its own. Instead, my focus today is specifically on how POCUS can be incorporated into the arrest and how it can add value without getting in the way of the basics like compression and defibrillation. So ultrasound has been used in cardiac arrest for quite a while. At first, the focus was mainly on prognostication, meaning trying to predict who was more likely to achieve return of spontaneous circulation and meaningful survival. But since then, its role has grown well beyond that. And by the end of this talk, you'll walk away with a clear, practical framework for when and how to use POCUS during cardiac arrest. So the very next time you're at the bedside with a patient in cardiac arrest, you know exactly how to apply it. So let's start with the first big question. Why even use POCUS in cardiac arrest? So there are really 4 main reasons. First, to identify reversible causes, the things that, if you catch them, can actually change the outcome. Second, to help diagnose cardiac arrest itself. Sounds obvious, but sometimes it's not clear whether a patient is truly pulseless, and ultrasound can help you sort that out. Third, to prognosticate, to get a sense of who is more likely to achieve ROSC and meaningful survival and who isn't. And finally, for procedural guidance, intubation, line placement, confirmation, ultrasound can be incredibly helpful in those moments. So it's not about replacing ACLS, it's adding another layer of information that can influence decision-making in real time. Now let's talk about reversible causes. And you've probably memorized the H's and T's if you've done any ACLS course. But POCUS gives us a real bedside way to actually go through them. Before I go through the list, let me ask you all, which of the reversible causes of cardiac arrest do you think can actually be detected with ultrasound? Let's see a few guesses in the chat before I get into the causes that I'm going to mention. All right, we got at least one. All right, we got tamponade, we got pulmonary thrombosis, pulmonary embolism. So a lot of the main ones. Tension pneumothorax, fantastic. And so we actually have even a couple more. Amazing. All right. So here's what we're actually looking at. So as mentioned, there's tamponade. You can quickly identify a, um, a pericardial effusion causing the arrest. There's tension pneumothorax, where lung ultrasound can help you pick this up in seconds. There's thrombus, as mentioned, so a massive PE is on the list. Now, it's important to note that the right ventricle often dilates in cardiac arrest, so the right ventricle itself isn't always specific, but if you actually find a DVT, that's a big clue uh, that a PE might be behind the cardiac arrest. There's hypovolemia, so a completely collapsing IVC can point you in that direction. And then there's hemorrhage. And so a fast exam, a focused assessment, sonography, and trauma showing free fluid in your abdomen could be your answer if there's bleeding from an internal organ or from trauma that you didn't know happened. So the ultrasound gives us the ability to narrow in on those H's and T's at the bedside, even if we know nothing about the patient's history, which is very common in the emergency department where I work. Now let's talk about POCUS pulse checks. So quick show of hands in the chat, or just say yes in the chat. How many of you have been in a code where one person swears they feel a pulse and someone else says, no way, I don't feel anything? Happens all the time, right? And the truth is the literature backs this up. We're not actually very reliable at detecting pulses with our fingers, especially in larger patients or sometimes in the middle of a chaotic resuscitation. I don't get we'll show the hands, but yeah, put in the yeah, we get a few always happens, right? So that's where point of care ultrasound can definitely help. Instead of guessing, we can put the probe on the carotid or the femoral artery and directly watch for pulsations. All right. On screen, you'll see the carotid artery beneath the internal jugular. And here's a pearl just to quickly mention. Don't get fooled by the color. Red versus blue doesn't tell you artery versus vein. It just shows the direction of flow relative to the probe. What really matters is when looking at the carotid artery, which is over here, you actually see pulsations in the artery, even without color. If you do, that's your POCUS equivalent of a palpable pulse. Not only is this more accurate, but studies have shown it's faster than manual pulse checks. So if you have no pulse on ultrasound, compressions can be restarted more quickly than manual checks. While you can simply look at the artery and see if it's pulsatile, another method of performing a POCUS pulse check is to compress the artery until the accompanying vein, either the femoral or carotid in this case, disappear, or rather IJ would disappear. Compression will bring out the pulsatility and make it easier to see that pulsatility. And one caveat that's important to mention if you're using POCUS pulse checks is if you've just pushed epinephrine, you may see a quick bolus of color flow through the artery. And that doesn't always mean that there's ROSC. So give it a minute and then recheck before making the call. Some of you may have seen literature on measuring peak systolic velocities to assess for ROSC instead of simple pulsatility. And if you haven't heard of this or don't know what I'm talking about, that's okay. While there is early work on this, there is insufficient data to fully correlate a specific velocity to return of spontaneous circulation. Meaning, if your blood peak systolic velocity is over 20 centimeters per second, but there is no arterial pulsatility, does that mean that compressions aren't needed? And this is yet to be borne out in the literature, so it's not recommended. But perhaps it's something that you'll see in the future. But remember, just looking with B mode or with color on ultrasound and seeing the compression or the pulsatility is really, really important and can help answer those, is there a pulse, is there not a pulse? Now let's move on to an important distinction, PEA versus pseudo-PEA. We all learned in ACLS that PEA, or pulseless electrical activity, is where you see organized electrical activity on the monitor, but no pulse. In reality, though, there are two different scenarios under that umbrella, and it's really important to differentiate the two because there are significant management implications for each. Uh, True PEA, which is over here on the left, with our image not showing up super well, but there we go. True PEA is there's electrical activity, but the heart has no meaningful contraction, like here, the left ventricle is not moving at all. On ultrasound, you'll see no cardiac activity. And these patients need epinephrine to help the heart generate contractility. And this is the classic PEA we all know. Pseudo PEA, or it's here on the right on this side, the monitor looks the same and there's no palpable pulse, but on ultrasound, a heart is actually beating, often very vigorously and hyperdynamic. The problem here isn't contractility, it's preload. There just isn't enough volume in the heart to generate a pulse. And this is usually due to hypovolemia or hemorrhage. So every time you see PEA on the monitor, you should be asking yourself whether this is PEA or pseudo PEA and adjust your management accordingly. In PEA, give epinephrine. This heart needs inotropy and chronotropy. But in pseudo PEA, epinephrine doesn't help and it might even hurt. What these patients need is fluid or blood, depending on the clinical scenario. Here's another really fascinating and awesome use of POCUS in cardiac arrest, identifying ventricular fibrillation. This image comes from the POCUS Atlas, and if you haven't checked it out, it's an excellent resource with a huge collection of ultrasound clips. In this clip, the heart is in VFib. If you look closely, you can see the ventricular walls fibrillating, quivering without a coordinated contraction. So why is this important? Sometimes fine VFib can be mistaken for asystole on the monitor, and those are two rhythms with very different treatments, as I'm sure you all know. One gets shocked and the other doesn't. And ultrasound can sometimes catch that subtle fibrillatory motion better than the monitor or even the defibrillator itself. So in rare case where the rhythm strip looks flat, but the ultrasound shows quivering myocardium, you've just found VFib and you've just changed the resuscitation plan and almost potentially saved a life. What we are talking about up until this point has to do with identifying the presence of cardiac arrest and intra-arrest diagnosis. Let's turn to another role for POCUS in cardiac arrest, prognostication. So here's an example. In this image, you can see the left ventricle with no cardiac activity at all. The right ventricle just shows some blood swirling slowly, sometimes called smoke. And this is what we mean by absent cardiac activity. Now, as you see this, the odds of a good outcome drop dramatically. Patients with absent cardiac activity are much less likely to achieve ROSC and survive to discharge neurologically intact, which of course is the real outcome we care about. Early studies in the 2000s even suggested that if you saw no cardiac activity, you could stop resuscitation altogether. But if you think about it, that actually creates a problem. If you always stop resuscitation when the heart looks still, of course nobody survives. It becomes like a self-fulfilling prophecy. Larger studies since then have shown that while absent cardiac activity is a strong negative prognostic sign, it isn't absolute and context matters. If this is an unwitnessed arrest in an older patient with multiple comorbidities and no cardiac motion, that may support the decision to stop. But if this is, for example, a witnessed arrest in a young patient with a potential for good recovery, the absence of cardiac activity doesn't necessarily mean the case is futile. So really the take home is ultrasound can provide powerful prognostic information, but it's one aspect of the clinical picture and not the whole story. And the other way around, you can have patients with a poor prognosis who have a little bit of cardiac activity on their ultrasound. So you really have to take this information of absent cardiac activity or present cardiac activity, understand that this is really important to help prognosticate, but really add this on to the full clinical picture in order to help make the decision either to continue resuscitation or to cease resuscitative efforts. Here is a patient that arrived in the emergency department after sustaining a gunshot wound to the upper abdomen. She was in cardiac arrest on arrival with a reported downtime of about 20 minutes. When we put the probe on the chest, the ultrasound showed no cardiac activity, but also something even more dramatic. The left ventricle, which is right here, is completely empty. There's literally no blood volume left entering the heart. This patient had lost so much blood that there was nothing circulating. This is an extremely rare finding, and this case is the only time I've personally seen it, and I work at a very high volume trauma center. But in this case, it underscored what we already knew. In a trauma arrest with a prolonged downtime, resuscitation would be futile. The absence of cardiac activity alone in someone with a prolonged downtime in trauma, even if it's penetrating trauma versus blunt, is already a very poor prognostic sign. Add to that the empty left ventricle, and the decision was made not to initiate resuscitation. And remember, this is important because trauma resuscitation is incredibly resource intensive. Ultrasound in that moment gave the team the confidence that continuing efforts would not have changed the outcome when you really want to do as much as you can in a young patient like this. Let's move on to procedural guidance. POCUS can also help with procedural guidance, especially with intubation during cardiac arrest. Now, normally, we confirm endotracheal intubation with the end-tidal CO2 monitor that you see here on the right. But here's a problem. In cardiac arrest, circulation can be so poor that there may not be enough pulmonary blood flow to actually generate CO2. So your detector might stay purple, not because the tube is in the wrong place, but simply because this patient isn't producing measurable CO2. And that's where ultrasound can step in. This image from Life in the Fast Lane shows a transverse view of the neck. You can see the trachea here, this round air-filled structure, and just next to it sits the esophagus, which is right about here. If the tube goes into the esophagus, you'll see a second round structure light up with air like here. So if you don't see that, if you don't see this image where under esophageal, you can be reassured that the tube is in the trachea. Ultrasound can also help identify mainstem intubation. After intubation, you can look for lung sliding. If there's no lung sliding on the left, but there is on the right, you may have advanced the tube into the right mainstem. To confirm, you can also look at the diaphragm. Oops, sorry. Don't have an image of that here, but place the probe as you would in a fast exam or looking for a pleural effusion in a lung exam. With bagging, you should see diaphragmatic excursion on both sides. So if you see bilateral lung sliding and bilateral diaphragm movement, the tube is likely in the trachea and not mainstemmed. It can't tell you if the tube is too high or low within the trachea. There are ways to do that, which include replacing the air in the tube with water. But in my opinion, it's too cumbersome to be practical. So personally, I just wait for the X-ray after that, and knowing that at least the tube is in the right tube, not in the trachea, not in the esophagus, and not right mainstem. I also want to highlight a less common but awesome use of ultrasound in the setting of cardiac arrest, the stellate ganglion block. Here's the image here's an image you're likely familiar with. The internal jugular and carotid artery can be seen here. The stellate ganglion, which is not something you can see, but it sits just below the carotid artery, and that's marked here with the star on the screen. The stellate ganglion is part of the sympathetic nerve bundle. So why is this important? In patients with refractory ventricular fibrillation, also called VFib storm, ultrasound can guide us in introducing lidocaine into the stellate ganglion. By blocking that sympathetic input, this intervention can actually help break the storm. Now, the evidence here isn't from large randomized control trials. It's mostly case reports and case series. But when you're facing refractory VFib and standard measures, including defibrillation, dual sequential defibrillation, aren't working, this is an option to consider. And critically, ultrasound guidance is what allows you to safely place the needle at this target. Success rates anecdotally that I've seen are upwards of 50%. So they're really, really good, and they are done in rare places. And these are for breaking the VFib storm. So let me ask, has anyone here ever seen or performed a stellate ganglion block in the setting of VFib storm? Put it in the chat. I'd love to know. It's one of those things that's rare but worth knowing about. And if I get nothing here, then I'll know that at least everyone has learned at least one thing coming out of this lecture. Awesome. So when should we be using POCUS during a cardiac arrest? All right. Remember, this is where we need to be careful. The core of resuscitation is still chest compressions and defibrillations. And so those are the proven lifesavers. And ultrasound should never interfere with them. In fact, at least one study has shown that if you don't set boundaries, POCUS can actually prolong pulse checks, and that's harmful. So the key is to weave ultrasound into the resuscitation without interrupting compressions or defibrillation. What I'm going to show you on the next slide is an algorithm for integrating POCUS into cardiac arrest management. And this algorithm is not from the ACLS guidelines, and it's not published anywhere. This is my own personal algorithm, the way I integrate POCUS step by step when I'm running a cardiac arrest. This comes from years of experience combined with the core understanding of what POCUS can do, while also keeping top of mind that defibrillation and continued compressions are key while searching for reversible causes. Now, let me walk you through how I actually integrate POCUS into the arrest cycle. Let me stop here and say, if you're going to screenshot anything from this presentation, it would be this slide and the next one to see the algorithm. Think of this as an ACLS algorithm with ultrasound woven in. So here's how it works. If the patient is in VFib or VTAC, forget ultrasound, they need defibrillation, maybe a stellate ganglion bond later on, but you're going down that pathway. If they're in PEA or asystole, that's where POCUS comes in. During the first round of compressions, I'm preparing the ultrasound, bringing it into the room if it's not there, getting gel on the probe, making sure that the machine is ready to go. I could also be assigning someone to do it if I'm the team code leader. At the first pulse check, I look for cardiac contractility. Is there any activity? Is this PEA or pseudo PEA? If there was asystole on the monitor, is this actually fine VFib? Then it's right back to compressions. Remember, I'm incorporating this information into my clinical decision-making as I continue through the resuscitation, adding this information as we go to really help with management as we go forward. During the next cycle of compressions, I check for lung sliding. Compressions prevent me from looking at the heart, but not really at the lungs. And this is where I ask, could a tension pneumothorax be the cause? At the next pulse check, I focus on the pericardium looking for tamponade. Then back to compressions. If you're truly savvy at ultrasound, you might be able to assess the pericardium and cardiac activity on the same pulse check, but here's where I advise some caution. Check one thing at a time. Checking too much at one time risks prolonging the pauses between compressions, something that needs to be avoided unless absolutely necessary. During the following cycle, I'll scan for the DVT on the right side or the left if there's more suspicion for the left. The next pause, I assess the IVC. Since compressions interfere with, since compressions interfere with this view, I need that pause to check for signs of hypovolemia. Then, while compressions resume, I'll scan the other side for DVT. After about 6 to 8 minutes of CPR, I loop back another cardiac contractility check at the next pulse check. And during the following compressions, if I'm still running this cardiac arrest, I'll do a fast exam to look for hemorrhage. So breaking down the pattern is really two things. So it's simple. So during pulse checks, I look at the structures that require stillness to actually see the heart, the pericardium, the IVC. During compressions, I look at structures I can assess without interrupting CPR, lungs if you can, DVT, fast exam. I check for one thing during each component of the algorithm. This way, POCUS flows within the existing ACLS algorithm. Now, I'll admit that this sounds rigid on paper, and in practice, I adopt based on the clinical context. So, for example, if the patient's abdomen is distended, I may do the FAST exam earlier. If the DVT is high on my suspicion list, I might prioritize that. But overall, this systematic approach and doing one thing during compressions or pauses ensures I don't miss reversible causes, and I never let ultrasound extend the pause. Now let's talk about avoiding pitfalls, specifically how to decrease pauses when using ultrasound during a code. So the slide has a mousetrap on it because that's a trap we all need to avoid, letting ultrasound prolong the pause. If your scan delays compressions, I've said it a bunch of times and I'll keep saying again, you've made the resuscitation worse and not better, and that would be an argument against ultrasound. So how do we prevent that? So let's get back to the algorithm and see a few strategies I use. Prepare early. With about 10 to 15 seconds left before a pulse check, I have the nurse or code leader give me a countdown. At 15 seconds, I make sure gel is on the probe. At 10 seconds, I start lining up my subxiphoid view while compressions are still happening. That way, when compressions stop, I already have the view and can use those precious seconds to record. Now, during the pause, here are some more strategies that you can use. Firstly, is just get the clip, especially if you're early in your ultrasound journey and can take you some time to get the view. Don't waste the pause trying to capture the perfect image and interpret it at the same time in real time. Hit record, save a short clip, and then review it during the compressions. That keeps your pauses short. Second is use the timer on the machine, the clip saving. Most machines save clips at around 6 seconds by default. So if you start recording at the beginning of the pause, you press the save clip button on your machine, you'll naturally stop scanning when the recording stops. The machine might make a noise, and at 6 seconds, you'll stop well within the 10-second window. Have someone prompt you. Ask the code leader or timer to give you a hard stop at 9 seconds, and then say hands off. You have to stop even if you're almost there, and you can always try again at the next pause. So the principle is actually quite simple. Ultrasound should fit into the code, not slow it down, and not prolong pauses. And using discipline here, especially if you almost have the view and you just want to get it, but actually making sure you get your hands off, does make all the difference. Finally, let's talk about the best view to use during cardiac arrest, which in my opinion is the subxiphoid view. And here's why I prefer it. If you use a parasternal long axis view, you're putting gel right where the compressions need to happen, right on the center of the chest. And that can make the chest slippery and actually reduce the effectiveness of compressions. The subxiphoid view avoids that problem. It's relatively easy to obtain, you can line it up during compressions, and you're not interfering with the compressor. If for some reason you can't get a good subxiphoid view, say the patient has a lot of abdominal air, or they have a barrel chested from being COPD, then I go to an apical 4-chamber view as a reasonable alternative. But the point here is choose a view that won't interrupt compressions. All right, now let's answer the last question. Who should actually be doing the ultrasound? The key here is to have a designated sonologist, someone whose only job during the code is to handle the ultrasound. It should not be the team leader. It shouldn't be the person managing the airway. If you have enough people in the room, and I recognize that a lot of you may work where you're the only physician or clinician around, so this is specifically if you work in somewhere with a lot of people, you want one person to focus solely on following the ultrasound algorithm. That way, the team leader can focus on running the code while the sonologist can feed back findings quickly and clearly. as part of the overall team. And experience matters. This isn't the time for someone's very first ultrasound. You need a clinician who's already comfortable because the scans have to be both fast and accurate. For example, in my shop where I work, I have residents running the code typically as I work in an academic center. If that's the case, I'll often step in as the sonologist as I'm typically the most experienced person in the room. But if I'm running the code and I have a senior resident who I know is competent with ultrasound, I'll let them take on the sonologist role. Point is give ultrasound to someone with experience if you can, and keep the role clearly defined the same way as you define a team leader, an airway, medications for nurses, IV, etc. Finally, just before we close, I want to touch on TEE, or transesophageal echo. So before we actually start talking about it, do any of you already have TE available in your ED or ICU where you work? If you do, type yes in the chat. I'd love to see it. Oh, we got one available in the operating room. Fantastic. So some emergency departments and ICUs are actively using it during cardiac arrest, and where it's available in the OR, you're going to use it in the OR in cardiac arrest. But I think we'll see it spreading more widely over time. So why is TE so awesome and powerful when it comes to cardiac arrest? Firstly, it lets you monitor the quality of the compressions. With the probe in the esophagus, you can see exactly where the compressions are landing in real time. Are they really squeezing on the left ventricle, or are they on the outflow tract and actually hindering resuscitation or somewhere less effective? So you can guide the compressor's hands in real time, or if you have a Lucas or automatic compressor device, you can adjust its positioning in real time. Second, it provides continuous cardiac assessment. So instead of getting these quick snapshots between compressions, you're watching the heart the entire time. Third, it gives better detail. If you've ever struggled with poor transthoracic windows, which can be a struggle even when patients aren't in cardiac arrest, but especially when they are, TEE can often solve that problem. And lastly, it can give you a more accurate diagnosis of rhythms like ventricular fibrillation. Remember how I said fine VFib can sometimes masquerade as asystole? So with TEE, you can often see it more clearly in real time. So TE offers constant detailed cardiac assessment throughout the resuscitation without worrying about the pauses. It's not available everywhere yet. As we can see on the chat, only one person said it was available. It's not available in my emergency department, but it is available in a fair amount of EDs and ICUs, and it's where we're headed in the future of ultrasound and resuscitation. So let's bring this all together, and then we'll get to the questions. So we've covered the why, identifying reversible causes, helping with diagnosis, prognostication, and guiding procedures. We talked about the when, weaving ultrasound into the arrest cycle without interfering with compressions or shocks. We've gone through the how, using disciplined strategies to keep pauses short and focused. And we finished with the who, making sure there's a dedicated, experienced sonologist at the bedside when available. POCUS won't replace the fundamentals of cardiac arrest management. Chest compressions and defibrillations still saves lives and are the core of cardiac arrest management. When it's used the right way, ultrasound gives us real-time information that can guide resuscitation and potentially reveal reversible causes. And really, it can change the entire course of the code. I'll stop here so we can open it up. I'd love to hear your thoughts and questions, whether it's about technique, workflow, cases, whatever is it you'd like to talk about. I have my email and website up on the screen here, and then Petri POCUS or myself, you can follow on all these platforms.
Thank you, Dr. Gutman, for a wonderful presentation. And to our audience and our viewers, Dr. Gutman has prepared a few quiz questions for you. I'm going to launch those shortly before we get into our Q&A portion of the webinar. So those questions have been launched, and please go ahead and answer those questions for us. And then, so Dr. Gutman, as they are answering those questions, we can begin our Q&A portion of the webinar. And then we'll go over
Sure.
those answers like in between. I'll switch back and forth. And so one of the first questions that we received during your presentation was, wouldn't cardiac activity will always be absent in anesthetically? Many of these achieve ROSC.
Yeah, that's a great question, and thank you, Rip and Meat, for the question. Cardiac, if there is true asystole, cardiac activity will be absent. What I mentioned is that you might see fine VFib, which looks like asystole on the monitor, so that would be a reason to look. And I'm just gonna look at the second part of your question. Many of these will, if they're true asystole, many of these will not achieve ROSC, but some of them will. And that's why I talked about really putting it into clinical context, that it's a data point. It's a very strong data point, but it's a data point that you work into your arrest. So if you're working in the emergency department, like I said, someone who's relatively young, witness arrest, maybe they had a shockable rhythm to begin with. These are positive predictive factors in arrest that make it more likely. So then, even if they're asystole, you might choose to continue the resuscitation. But if there's someone who you feel like would not is may not benefit for continued resuscitation, absent cardiac activity is that strong and negative predictive factor.
Thank you. And continue to answer the quiz questions if you haven't already. Looks like about half of you are in, so really good. And I'll continue to ask Dr. Gutman your questions. And if you have additional questions, please feel free to add them in the comments section or the Q&A box. The next question, Dr. Gutman, is what is the role of AI-enabled POCUS in cardiac arrest versus normal POCUS? And then there's the second part of that question. Could it revolutionize management and reduce pauses?
That actually can be an entire lecture in and of itself. I actually gave another webinar a couple of weeks ago, in July, I think, that actually talked about this whole thing. But in a short answer, yes and yes. AI in point of care ultrasound. So right now, specifically in cardiac arrest, it hasn't been specifically looked at. What AI can do is improve the ability of a user to actually get the image. And there's also a role of diagnostics. So AI has the ability now to also do some diagnosis in the middle of, for example, cardiac, lung, and some of these other things. So I think it will integrate in cardiac arrest in the same way that it will be integrated in all the other areas of management and the ability to diagnose. I think it'll be hard from an educational standpoint to guide a user in the middle of an arrest. It'll take way too long. But I think as AI improves and its diagnostic ability improves, it's gonna come into more and more into cardiac arrest management. So yes to all of that. It's definitely the future in cardiac arrest specifically. It's not here yet, but it can assist in learning ultrasound much faster. It has great educational tools, especially in cardiac ultrasound, to allow someone who's a novice to become much better faster. So then it can integrate faster.
Thank you. And then we had another question that came in the comments. Why no plaques or slacks or
Yeah.
plaques o slacks? Sorry.
Plaxis Slack. Yeah. So the why I don't do a parasternal long axis during arrest is because then you're putting gel kind of all over the chest. And then when someone, you can imagine if someone's then going to go do chest compressions during that, they're going to be all over gel and it's going to be kind of slippery and not have as effective as compressions. So that's why I use subxiphoid. To be honest, I don't use subxiphoid a lot of the time in my regular point of care cardiac ultrasounds. I'm usually using a parasternal long and an apical 4. In this case in particular, it leaves that chest free. At the same time, it allows me to prepare before. So think about if someone's compressing, I can't really put my ultrasound probe on the where a parasternal long axis view needs to happen because someone's hands are there, or the Lucas automatic compressor device is already there. But if I have a subxiphoid view, I can actually already get a view of the heart right before the compressions even stop, so it allows me to do it faster.
Thank you. And again, if you have any questions, we still have time for your questions. So please add them to the comment sections, the chat box, or the Q&A box. I am going to end the quiz and share the results with you all, and you'll see them on your screen. And then I'm also going to share a learning score question. This will be left up for the duration of the webinar. So take your time in answering these questions. It'll be left up to the end of the webinar.
And I left if you have more questions after you think of something or want to chat, or also if you're from my standpoint, if you're in the USA especially, and you want to build up your ultrasound program to be reimbursable, billable, have a good workflow, please send me an email. If you're anywhere in the world, I have online lectures on my website. So the website is up there, and I do live custom courses. So whatever specialty you're in. We're going to be setting up this virtual live teaching very, very shortly. So even if you're not, if you're even if you're across the world from the United States, we'll be able to do something virtually. So keep an eye on that. You can follow Petri POCUS on social media and see where when that comes in, or simply just send me an email and say, hey, I'm interested in learning, or I'm interested in 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 getting some education on doing point of care ultrasound in general.
Yes, and we'll be sure to leave Dr. Gutman's information and what's presented on the screen now. It will be in the follow-up email that you all will receive next week with the recording as well. So we'll be sure to leave Dr. Gutman's contact information for questions. We do have two questions that came in, Dr. Gutman. We do have time for them. The
All
first
right.
one, as more people become skilled in POCUS, do you think that POCUS in this type of emergency will become a standard of care?
Yes. I think it in many ways uh, it is becoming a standard of care, at least to look at cardiac activity and not cardiac activity is very standard, and this has been done for a long time. And as more people learn point of care ultrasound, and as it becomes more integrated into medicine, it will become the standard of care. In some cases, is already the standard of care.
Yes.
If you don't already know point of care ultrasound, it's really something that needs to be learned.
Thank you. And our last question is, can we use ultrasound to guide intubation?
Yeah, great question. So I addressed that a little bit earlier, and so ultrasound guided intubation can be done in three ways. The one I didn't talk about is where you can actually, when I showed this picture, and I'll bring it. Uh, let me bring it up here. I think I'm already sharing. So let me stop share. Let me just get back to it. Close these learning questions. Just going to try to share it one more time so I can go back to that slide. All right. Through here. Oh yeah. So here's for point of care ultrasound guided intubation. So this picture here with the trachea, this is a tube in the trachea. So when the ultrasound is actually put into the is actually put when you're actually putting the tube in, you can actually see the trachea kind of move and kind of light up is not the right word, but you can see actually a tube or movement within the trachea. And then if you don't see it in the trachea and you see it in the esophagus on this side, that tells you that's in the esophagus and not the trachea. So that's how it can combine. That's how it can guide intubation. So this can be done dynamically, whereas you're seeing something go through. Personally, I do this more statically, where the intubation happens, and then I look with the ultrasound in real time and make sure that it looks like this, and and not like this. And then the next thing I mentioned is looking for lung sliding. You can look for lung sliding on both sides and look for diaphragmatic excursion as well. That's how it can guide intubation.
Awesome. Thank you. And that concludes our webinar for today. There's no other questions in the Q&A box or the comments. Dr. Joshua Gutman, we thank you. Thank you for being our presenter. And we thank our audience today. Thank you for viewing and for attending today's webinar. A recording of this webinar will be made available on the POCUS.org website in approximately 1 week, and you will receive a link via email. Thank you again for attending today's webinar, and we look forward to seeing you on a future webinar. Take care.